25th convention. We are now on our Meet the Expert session. So for this particular session, we'll be talking about AIDS, which is a hot topic here in our country right now. So our Meet the Experts is entitled Making Headway in Pediatric HIV. So our first speaker is Dr. Marimel Pagcatuipunan. She is an associate professor of the University of the Philippines College of Medicine, or UP-PGH, and an assistant training officer and treasurer of the Infectious and Tropical Disease section of UP-PGH. And she is currently the chair of the Research Grant Committee and Public Relations, Advocacy, and International Affairs of PIDSP. So to talk on management of infants born to HIV-positive mothers, let's now welcome Dr. Marimel Pagcatuipunan.
Best friend Edna. Good morning, everyone. Okay, do you have your breakfast already? So I think there is a breakfast being served in this room. So while having your breakfast, we'll start with our prevention of mother-to-child transmission of HIV in infants. Okay. So for this morning, I will just discuss with you our own local policy on PMTCT. Okay. So actually we also have so many materials that you can use, and these are all downloadable on the website, WHO, UNICEF, or CDC. Okay, so let's start. What is PMTCT? Okay, medyo ano man siya. Mahirap sabihin. Okay? So it's a mother-to-child transmission of HIV. From an infected mother to her baby, can be during the pregnancy, labor, and delivery, and breastfeeding. So MTCT is also referred as a vertical transmission or perinatal transmission of HIV. So most of the children infected with HIV actually acquire the virus through the mother-to-child transmission. So the prevention of transmission is a common term for programs, services, and then interventions designed to reduce the risk of your transmission. Okay, so let's look at the rates and the timing of the mother-to-child transmission. So the risk of transmission without intervention, okay, is approximately about from 20 to 45%. So the risk of transmission may be during the breastfeeding period, depends on whether the mother uses safer breastfeeding practices, or avoiding mixed feeding, and then the duration of breastfeeding. So if the mother is breastfeeding for 6 months, okay, and she's not treating herself, the overall transmission is actually 20 to 35%. But if the breastfeeding is up to 18 to 24 months, the transmission rate is even higher at 30 to 45%. So reducing the transmission through core interventions can be reduced by 40 to 70% through core PMTCT interventions, okay, like giving of ARV therapy or antiretroviral therapy or prophylaxis, and it should be in combination with other interventions. Okay, I'll discuss that later. So in industrialized countries, where women infected with HIV receive the long-term combination of ARV therapy. So the mothers, while they are pregnant, are being treated, okay, and do not breastfeed, and where elective cesarean sections are safe, feasible, and commonly performed, the rate has been reduced to how many percent? 2%. So that's very, very good, diba? But actually, you will see later, Dr. Rausa will discuss about in their country, it's actually already elimination. Okay? So that means it's even lesser than 2%. So, in this chart, or graph, okay, it says the new HIV infections in children aged 0 to 14 years. Okay, look at the graph, no? It goes up, but this is global. Okay, this is not our data. I will show you our data. Okay, so from the start, of the HIV in the world, really, so there's actually initial increase, but now it's decreasing again, and the aim is actually to bring it down to 0. Okay. So, let's look at the global data. Okay. In the Middle East and the North African region, it has shown that at least the least amount of progress. Okay, understandable, because in these areas, poor countries, and in the Middle East, some of them are war-torn areas. Okay, as nearly 1/3 of women living with HIV will pass the virus on to their children. In Asia and the Pacific and the Western and Central Africa, it's actually well above the global average of 10%. Okay, in June of 2016, Armenia, Belarus, Cuba, and Thailand, look at this data, has been certified by WHO, eliminated already. Okay, so by 2015, 7 countries in East and Southern Africa have greater than 90% coverage of PMTCT services. Okay? So East and Southern Africa, okay, has achieved the largest decline anywhere in the world, falling from 18% of infants born to mothers living with HIV to how many percent? 6%, in 2015. So now let's look at our local data. I think this was already shown yesterday, remember, during the talk of Dr. Asali. But let's actually focus on those pregnant women living with HIV. Just for January to November 2017. How many are reported? No, these are actually reported, just reported. So, pregnant women living with HIV, how many? 67. So, these are the infants now that we have to look out for, because we want to do PMTCT with them. Okay? But the cumulative data that we have is actually 216. Okay? So, from January of 1984, which is the start of our HIV data here in the Philippines, so first case of HIV, up to November 2017, the 1,965 or 4% of the overall reported cases were actually 19 years old and below. Okay? And the 135 of them, out of the 965 or 7% were actually children. And among them, 132, so isa lang po yung naiwan, were infected through mother-to-child transmission. Okay, so sad, di ba? And 1,830 out of the 1,965 or 93% were actually adolescents, and among them, 8 of them, or less than 1%, were infected through mother-to-child transmission. So we still have a very long way to go to the elimination of the transmission from mother to child. So, I will now show you our own policies, local policies, the DOH policies regarding our PMPCT program. Okay? So the comprehensive approach to reducing HIV infection in mothers, infants, and young children composed of 4 elements. Okay? The primary prevention of your HIV infection. The next element is the prevention of unintended pregnancies among women with HIV. Number 3 is the prevention of HIV transmission from women to transmission to their infants. And the 4th element is the provision of treatment, care, and support to these women. And not only the pregnant women, but also to their children and their families. Okay, so element 1 is prevention of primary infection, HIV infection. It's just the ABCs. A, abstain. Okay? B, be faithful to an HIV uninfected partner. And if you cannot prevent this, the C is the condom use. Okay? And the condom use should be consistent and correctly. Baka bali-baliktad. Bila nung nagkagulo. Okay? The element number 2 is prevention of unintended pregnancies, because we all know, especially if they're adolescents, diba? So they have to have access to counseling and then referral to family planning clinics. Also to have a safe, consistent, and effective contraception. The third, which I will discuss more this morning, would be on the core interventions, no? Because in the case of a mother infected with HIV, then you have to do the testing, counseling, the use of antiretrovirals, safe delivery practices, and then infant feeding. The last would be for the provision of the treatment and care and support would be the following. Okay. So, some definitions: antiretroviral treatment and prophylaxis. Okay, treatment is the use, long-term use of these drugs to treat maternal HIV and AIDS, and then prevent the transmission to the child. Okay, so because the treatment reduces the viral replication and the viral load. This is very important in the HIV because the virus, no, the viral load would really affect the transmission of the disease. So you treat the other maternal infections like STDs, okay, and then protect the HIV-exposed infant, improve the overall health of the mother, and then requires ongoing care and monitoring. When we say prophylaxis, it's just a short-term use of these antiretroviral drugs. Okay? So these are the factors, no? Maternal and neonatal factors that may increase, so the other way, no? Increase the risk of HIV transmission. So where does it occur? During pregnancy, no? Because of the high maternal viral load. For example, the mother is newly infected, okay? Or in advanced AIDS. When you say HIV positive lang mo siya with the virus. But when we say AIDS, there's clinical symptoms already. Okay? Or, so in pregnancy, they also have some sexually transmitted infections. Okay? And during labor and delivery, again, because of the high maternal viral load, or this one is part of the risk, rupture of membranes or for more than 4 hours. Okay? Then the invasive delivery procedures that will increase contact with mother's infected blood or body fluids, okay, during episiotomy, okay, or chorioamnionitis, the presence of infection, preterm delivery, and then low birth weight. Now, hindi pa safe yung bata pag pinanganak siya, di ba? Because during breastfeeding, if the mother has high maternal viral load, okay, and in HIV, which is very specific for HIV infection, we do not encourage mixed feeding, meaning the mother is breastfeeding at the same time giving the artificial milk. because this will actually, studies have shown that if you have mixed feeding during the first 6 months of life, especially, there's microabrasions in the intestines of the baby. And those microabrasions will allow the virus to go to the circulation of the child, so that there's transmission there. So it's either pure breastfeeding or artificial milk. Okay? Or if in the presence of breast abscesses, if the mother is breastfeeding, nipple fissures, or the presence of mastitis. And if the baby will have oral diseases, okay, or like thrush or sores. Okay. Look at this regarding the rupture of membrane. The footnote there says that studies have found that there is an increased rate of HIV transmission after a mother's membrane have been ruptured for more than 4 hours. So the longer the membranes are ruptured, the higher the risk of HIV transmission. So this is a graphical. So I will discuss the stages. This is what WHO and what DOH is adopting now for our program, the option B+. Okay? Which means there's lifelong use or treatment for the mother, pregnant mother, and then while they are breastfeeding, okay, and on this violet side would be on the effect to the infant. Okay, so let's discuss the first side, the pregnant and breastfeeding women. So they have, once they are identified or tested positive, then they are started with ARVs. Okay? And these are just samples of combination. In HIV, is still a combination, parang sa TB, di ba? The treatment is the combination because our problems now are also the same with TB. We are now having multi-resistant ARVs. Okay? So we have to change their regimen. So we have to assess the CD4 baseline where possible. Okay. So the testing, in our implementing rules and guidelines for PMTCT, hindi ko na binuo, just the most important parts would be that all pregnant women and their male partners should be tested for HIV. So it's like when you are pregnant, we are being tested for CBC, urinalysis, and VDRL, for syphilis, because we all know syphilis will also affect your baby. So it's like we are now putting HIV testing there. So it's what we call now the opt-out option. When you say opt-out, it is part already of the medical care for a pregnant woman. Unless she will refuse, then she has to give a waiver that she is foregoing the test for HIV. Okay. So if the pregnant woman refuse to undergo HIV testing, then they will be required to have the other testings on her subsequent antenatal care visits. Okay, next. On this slide, I would just like to show you that it's a plan for the pregnant woman. Okay, childbirth plans, because we all know one way to transmit the HIV infection is through delivery, during labor and delivery, and then we have to start treatment, also maternal nutrition, and then discuss about infant feeding, kahit na hindi pa pinapanganak ng bata. So what we do in our clinics is we go to the pregnant women are actually referred to us at least a month before, any month before their, during their third trimester, so that we can discuss with them in the infant feeding and all the other tests that will be done to their child. Okay. So, once they are positive, ART or antiretroviral treatment shall be initiated on all pregnant women yung living with women, WL, with women living with HIV, regardless of the CD4 count or the clinical status. So before, I remember, lagi ko natin sasabi that the CD4 count should be less than 35%, or 350, depende sa value. Now, it's treat all. No? So, hindi na natin kailangan hintayin pang bumaba yung kanilang CD4 count. So, the ART shall be continued even after delivery because they are already positive. So, that is lifelong treatment already. Okay. Management of labor and delivery. Remember, I told you about the effects, if the high risk or low risk, okay, and if they have to deliver through cesarean section or normal vaginal delivery. Okay, in our implementing guidelines, the attending physician should consider vaginal delivery unless, okay, so it means these HIV-infected mothers can have a vaginal delivery. Actually, hindi na talagang automatic, di ba? Cesarean, hindi na ho. Unless one of the following conditions are present. So it means because they will be high risk, no? Like any signs and symptoms of prolonged labor, so yung rupture of membrane, diba? Or marked presentation or fetal distress. And also, we have to consider if there's signs and symptoms of other STI or sexually transmitted infection. Okay? The ARV medications have not been taken or was on ART less than 3 weeks. Kasi we all know that it's not, the viral load will be very high. Okay? So our target for these women is a viral load of less than 1,000 copies. Parang sabi niya, dami pa nun, but actually, if they are infected, millions of viruses yung nakukuha namin. So less than 1,000 copies of the virus will be safe, no, for vaginal delivery. So more than 1,000 option for cesarean. Okay, so elective cesarean section is considered when it is safe and feasible. Remember, kasi we are implementing this up to the barrios, diba? And so, yung mga birthing centers, they are now allowed to do vaginal delivery even if the mother is HIV positive, as long as she does not have those risks, okay? And done at the onset of labor or before rupture of the membrane. Okay? So, or there's rupture of membrane. So vaginal delivery is when the ARV prophylaxis or treatment has effectively reduced the viral load. So viral load is a very important determination for a pregnant woman to on her type of delivery. So on the side of the HIV-exposed infants, we call them HIV-exposed infants because they may or may not be infected. So when they are not infected, ibig sabihin, for life, hindi sila, yung risk is, wala silang chance to have the HIV unless adolescent age na nila. Okay? So we will not treat them at all. Okay? So, there's the two options, breastfeeding and the replacement feeding. So it will affect the duration of prophylaxis. Okay. And then we are now advocating for early infant diagnosis. That means at least before the 4 weeks of life, we have the infant tested already. Okay. And then the final diagnosis. So final diagnosis would be either positive or negative. So the management of HIV-exposed infant is to give prophylaxis. Okay, I'll discuss the drugs with you later. And then, early infant diagnosis should be at least at 4 to 6 weeks of life. Then we do the testing. And if the mother is breastfeeding, okay, so we repeat the test after cessation of breastfeeding. And if the infant is confirmed infected, then treatment is initiated. So we'll stop the prophylaxis and go to treatment immediately. Okay? And if there are other forms of STI infections in the mother, then the child or the infant should be evaluated for congenital syphilis and other forms of STDs. Just a note, this is not yet published, but Dr. Edsel this is his study on HIV treatment failure and acquired drug resistance after 1 year, just 1 year of ARVs. This is for adults, syempre. But because we all know kung may resistance sa mother, then yung type yun mabibigay na sa infant. Okay? So, the study show. Okay, so this is just one. So these are the drugs. Hindi ko na babasahin isa-isa sa inyo, kay marami na yung drugs na yan. But these are the locally available ARVs. And look at the resistance in unsuppressed, although the population is still very low, but we are now having, look at the third column, the overall resistance, 8%. So meron na tayong resistance to our first-line ARVs. Okay, so these are the ones that will be transmitted to the infants. Okay, so ibig sabihin kahit on treatment sila, nag-develop sila ng resistance to the drug. Okay, so now I will go to the prophylaxis, the infant prophylaxis for different clinical scenarios in the infants. So this is actually, hindi pa ho napipirmahan ang AO natin for this, but we hope na pag hindi na busy si Duque, mapipirmahan na niya to so that we can now implement this. Remember, before, we are just giving one drug as prophylaxis for infants. So that is nevirapine. Okay? That was 1 to 2 years ago. Okay? Now, we are advocating to give how many? It's like giving 3 drugs already. Okay? It's like prophylaxis is equals to treatment. Okay? Why? Because we always receive infants on the third row. Look at the third row. Infants born to mothers with HIV who are at high risk of acquiring HIV and is also breastfeeding. Okay, so ilan ang risk niya doon? The mother is not treating, or not taking the ARVs, and then breastfeeding pa, So, the child is now being given combination of 3 drugs. And the duration will be longer. The duration of prophylaxis will be longer, up to 12 weeks of life. So immediately, the babies, once they are born, the first dose of the drugs should be given within 12 hours of life. So remember to refer them also. So yung mga imminent deliveries natin, tapos di ba, doon lang natetest yung rapid test, then you have to call your friendly pediatric IDS so that they can plan the prophylaxis for the child. But definitely it would have to be 3 drugs. Okay. The fourth row is actually abacavir, or the ABC is actually a new drug, pero medyo old na siya sa Amerika. But new drug here in the Philippines because it is better. It's in a suspension formulation. Okay, and these are the combinations of the new drugs. So that is what we are actually trying to acquire for our program. Okay, so who are high-risk infants? Okay, those born to women with established HIV infection who receive less than 4 weeks of ART at the time of delivery. Wala akong tawad dyan sabihin nyo 3 weeks. Mahirap po kasi because once the virus is transmitted to the child, forever na siyang infected. So you have to treat that child for life. But once the child is not infected, normal siya, di ba? So it really has a very big impact in the life of the infant. Okay, so the second one is born to women with established HIV, but the viral load is still very high, or more than 1,000 copies. So yun lang yung cut-off natin. Okay, in the 4 weeks before delivery. Okay. Or born to women with incident HIV infection during, so dun lang, no, nalaman na, or during breastfeeding. So some of these infants are brought to our clinics, no, 1 week old na and haven't started their prophylaxis. So magkakaroon tayo ng problema. Okay? So, and the other is identified for the first time during the postpartum period, or with or without a negative test, prenatally. So, there are antibody tests, no? And we also have the HIV viral antigen tests. So these are actually the new ones, the P24 antigen test. So it's very specific to measure one of the proteins that is specific for your HIV virus. Okay. When do you do the diagnosis? No? We all know that antiretroviral treatment and for prophylaxis will reduce, but does not eliminate the transmission of HIV kung hindi siya core intervention, yung lahat ng interventions. And since that the maternal antibodies will cross the placenta kasi positive si mommy, di ba? So antibody testing is not recommended prior to 18 months of age. So what we recommend is HIV DNA PCR. Okay? This is not the antibody test, but you look for the PCR, the HIV PCR. So we do this 4 to 6 weeks of age. If the infant is positive for one test, then HIV infected. If negative, so it's not infected. But if the mother's or the infant is being breastfed, okay, at 6 weeks of age, if he is positive, no, then positive na siya. But at 6 weeks of age, if he is negative, but still breastfeeding, so you have to repeat the test 6 weeks after cessation of your breastfeeding. So it would depend on the mother. Okay, so usually we encourage breastfeeding up to 6 months of life ng baby, di ba? So you do repeat the test 6 weeks after. Okay. And thereafter, no, antibody test can now be done after 18 months of age if the child is not breastfeeding. Ito yung mga late na natin nakukuha, for example. No? If after 18 months of age, not breastfeeding, negative, so negative yung positive. But if the child is also breastfeeding, so when there's negative at 18 months of age, but breastfeeding, you repeat the test 6 weeks after complete cessation of your breastfeeding. So counseling is part of the care for women, okay, because they have to be encouraged, no, to take their drugs and to take care of their babies and to give the drugs, the prophylactic drugs, to the babies or to the infants. Okay? And also, if the mother opted not to breastfeed her child, then you can actually tell them about the importance of these other concerns. Okay? And last would be follow-up care, treatment, and support for the mother, the infant, and their families, including, syempre, yung partner or the father. Okay? So follow-up care includes adherence to the drugs. We may have to give cotrimoxazole prophylaxis, okay, and then the other concerns for the mother and the family. Okay, so the key point is the risk of mother-to-child transmission without intervention is high, no, up to 45%, but with effective PMTCT programs, it can go to, 2%, pero what we want is Zero, di ba? Kaya nga, USA will discuss about the best practices of Thailand. Bakit sila eliminated na? Ang Pilipinas nasan? Mataas pa rin tayo. And it should go down, sabi nga ni USA. It has to go down. Okay, so the comprehensive approach is needed to prevent HIV infection in infants. It always begins with us, pediatricians, because we are the ones receiving the infants. Okay, now, the question is, saan kami kukuha ng gamot? Di ba ho, yun ang tanong nyo. So we have all the list of the treatment hubs and satellites. Please, all over the country na ho ito, please refer them to these treatment hubs because all the drugs are free, okay? Free, so they don't have to buy it.